Sorry, I'd had a difficulty unmuting. Sorry about that. We got a few apologies for today, so I won't worry about those. We're going to have one latecomer come late afterwards. But John Boomsma has invited Professor Richard Wassersug, I'll have to have a look. Sorry, Wassersug, to join the meeting today, and from Canada, and we really, really appreciate him being here. We've got a really good roll-up. I can't see everybody's name because my computer screen's not big enough, and I can scroll left or right and find more people. But I'd just like to welcome everybody, and for a lot of people, it'll be their first time on our advanced group meeting. So I hope you really get something out of it. And thanks to John for the amazing amount of work he's done in having Richard present with us today. Because John's done all the hard work and everything, we might let John run the meeting for a while, if you don't mind, John. Thank you.
Yeah, you're most welcome. Thanks, Nev. Yeah, so good morning, everyone. I'll begin my introduction with a bit of a brief bio of today's special guest speaker, Richard, who has a PhD and is now a retired Professor of Anatomy and Neurobiology from Dalhousie University in Nova Scotia in Canada, and is currently an honorary professor in the Faculty of Medicine at the University of British Columbia. Richard's research is primarily on the psychological challenges of prostate cancer treatments, which we all know about, with a particular focus on androgen deprivation therapy or hormone therapy. The primary goal of his research is to develop ways to help men and their partners to adapt to the side effects of their cancer treatments. This research evolved from his own experience as a prostate cancer patient that started over 25 years ago when he was diagnosed. Richard has now been on a couple of different ATD protocols almost continuously for over 20 years. Richard is the lead author on the book Androgen Deprivation Therapy, which came out as the third edition last year. And an important part of his life has been as a science communicator. For 10 years, he was a columnist on the TV science news show Daily Planet, as well as the scientist in residence for an additional 5 years for the Canadian Discovery Channel. He has also published over 30 essays in popular newspapers and magazines. I won't list them all, but it's a very impressive list, including The New Scientist and the New York Times. Richard will be talking about both his own personal ADT history today, where he has been using a natural estrogen called estradiol applied to his skin for ADT, and has had a really good PSA control for over 20 years. He'll also be talking about the research that's coming out of the UK, showing that this is a good and safe option for men who need hormone therapy to suppress their testosterone, but don't like the side effects of drugs like Lupron or Zoladex. Nev's already done the introduction to everyone, but I'd like to introduce everyone, and in particular, Sarah Weller, the Global Director of Prostate Cancer and November, and Anne Savage, the CEO of the PCFA, will hopefully be joining us shortly as well. Richard has a few slides to get through, and although we can take questions during the presentation, if possible, can you wait till the end of his presentation? Well, there'll be plenty of time for Richard to answer everyone's questions. But if you need to go and it's important, put your hand up or use the chat icon. So thanks very much, Richard, for spending the time preparing this and talking to us, and I'll hand over to you.
Thank you very much. Let me start by asking, can you all hear me? Yes, okay, thank you. So I am originally from New England in the United States and have a Boston accent, and I talk fast. So if you can't understand me, please signal to me to slow down. And I will try to stop to take questions along the way. But let me start by sharing my slides, if I can. And that's not coming up right now. Share. That's not the slide I want. That's a whale, by the way, jumping there. So let's get over to my PowerPoints. And at this point, you should start to see a slide. Okay. And I'm going to minimize that. All right. So this is an unusual talk. It's unusual in the sense that typically I'm, as a patient, you get talks from researchers, and there's sort of like two worlds. There's us patients, and then there's the researcher. I'm in both worlds. And so I'm going to be talking as a patient about my own experience over these last 20 or more years with hormonal therapy. And I'm going to talk about some solid research supporting the protocol that I've been on. So hence, I'm going to be talking about ADT, me, and the E stands for estradiol, a natural hormone in women. Now, let's get it, see if the slides advance. So as you just heard, we have a program in Canada, which led to that book, Androgen Deprivation Therapy. It's our national ADT educational program. And I co-lead that with Dr. Lauren Walker, a clinical psychologist in Alberta. And these are the various organizations that have supported our program for the last decade. As well, I've been funded by a few drug companies to give presentations about ADT and doing some consulting for them. All right, so I'm going to use some technical terminology. Most of you will know most of these terms, I'm guessing, but I'll walk through them. So my slides, PCA stands for prostate cancer. ADT stands for androgen deprivation therapy, and we typically are often called hormone therapy, but it is the same thing. Estrogens are hormones that are commonly associated with women, but we men normally have estrogen in our body, and we make it from our testosterone. So if we go on drugs that suppress our testosterone, we're going to lose not just our testosterone, but we're going to also lose our estrogen. Estradiol, which is E2, is the most common natural estrogen in both men and women. And you're going to hear about taking this hormone through the skin, which means transdermally. And that is one way to get it without using injections or having to swallow anything. So you'll see me use the abbreviation TE2 for transdermal estradiol. And there it is. TE2 is transdermal estradiol administered through the skin via patches, topical creams, or gels. Okay, so in my talk, there's going to be really two parts. I'm going to give you my personal history with prostate cancer and ADT, then the history of using estrogens for ADT, and in fact, that was what was ADT before we had drugs like Leukeran or Zoladex. Before they came on the market, they used a synthetic estrogen for hormonal therapy. So in some ways, I'm revisiting the past of hormonal therapy in this talk. Okay, but then I'm going to get into the rationale for specifically using estradiol in the transdermal mode for ADT. And then I'm going to, last quarter or so of my talk, review the status of a study that was just published, presented at a cancer meeting about 2 months ago in Europe, comparing transdermal estradiol to the standard drugs like Leukeran and Zoladex for use of ADT. I'll give you the punchline there. It is as effective, appears to be as safe, and has a better side effect profile. Okay, and therefore that's where I'm going to end up when I talk about the case for, but also present some barriers to making transdermal estradiol an acceptable alternative to the standard drugs for using ADT. Okay, so here we get into my history, and to make it clear, whereas I run a program to help men deal with the side effects of ADT, since my own treatment has been off-label, I have not promoted it, and it's only now because it is has been, some research results from the clinical trials group in the UK have established that its benefit, its safety, and so forth, that I'm actually talking about it. So even in my book and in our classes, I did not promote it, transdermal estradiol. But here's the background history. When I was 52 years old, and that was 27 years ago, a close friend got prostate cancer. Back then, I knew nothing about prostate cancer. I mean, really nothing. I had never even heard of a PSA test. When I got my first PSA test, it came back 19. Shortly after that, I had a biopsy. It came back as a Gleason 3-4. I think it would probably be regraded as 4-3 these days. Sorry. A few weeks later, I had an open prostatectomy, but my post-surgical pathology report said that I had extracapsular extension, seminal vesicle involvement, not great signs, but my nodes were negative, my surgical margins were negative or clean. Hence, I had what was then considered T3A, or intermediate marginal to advanced prostate cancer. This is not great, but my PSA was measurable on the next test and continued to rise. Within 6 months, it was obvious that I still had prostate cancer cells in me, even though I no longer had a prostate gland. So I had salvage radiotherapy. But my PSA kept climbing. So many, I guess most of you may have been in this position. I therefore had missed my chance for a cure, and I was heading for hormonal therapy. I'm trying to get that slide to advance. So I started on Lupron. Actually, here in Canada, we call it Lupron, but it's the same drug for ADT. And some background, approximately half of all men treated for prostate cancer will be on ADT at some time in their lives. Because of early detection, prostate cancer patients are now starting on ADT at a younger age than in previous years. And some prostate cancer patients diagnosed early may now be on ADT for over 20 years. So this is a big turnaround. When we first started ADT, before the PSA tests, too many men were unfortunately diagnosed with advanced prostate cancer, and we didn't see survival this long. But now, with like 20 years for many patients, we have to worry about not just their survival, but their quality of life. For most of us now who start on ADT, we start on when our cancer is largely asymptomatic, because the PSA test can pick that up. As such, any long-term suffering we experience is more likely from the side effects of the treatments rather than from the disease itself. So I started on androgen deprivation therapy with a Lupron depot injection when I was 54 years old. Now, Lupron is in a class of drugs called the LHRH agonists. I'm not going to give it a long name for that, and which are among the most common drugs. These are most common drugs used to treat prostate cancer when it is spread beyond the prostate gland. Lucrative drugs like it have a lot of side effects. So this is the area where I started getting involved in the research. And that's because androgen deprivation is effectively chemical castration. We talk about castration as suppressing the testosterone level so low that sexual function is lost and so forth. So ADT is a chemical castrating agent. And I experienced just about all of the known side effects of ADT. All right, so here's a long list. And I'll just run through them quickly, but I think many of us who've been on any of these drugs will recognize most, if not all of them. Erectile dysfunction. Osteoporosis refers to a weakening of the bones, so they're more likely to break. Hot flashes, loss of sexual interest, genital shrinkage, some gynecomastia. That refers to possible breast development and nipple sensitivity. Typically with the drugs like Lupron, that isn't common, but I'll come back to that later when I get into estradiol. Impaired memory and attention. There's more and more trials suggesting this on a larger scale. That is to say, not everybody is going to experience that, but when they do these huge studies, largely out of Scandinavia, with large sample sizes, it tends to show up. Then there's issues around weight gain as fat and loss of muscle mass. So that's where things get rough for us, along with the hot flashes. That is, if we're gaining weight but losing muscle mass, just getting up a flight of stairs becomes more difficult. And indeed, going on to a second list here, anemia, a shift in the ability of the blood to transport oxygen can occur with these drugs. That can lead to fatigue. Collectively, this can lead to insomnia, depression, and so forth. And overall, there is, just getting into serious medical stuff, an increased risk of diabetes, certain cardiovascular disease, as well as shifts in emotionality, men maybe become more tearful in these drugs and so forth, and loss of various the physical signifiers of masculinity, such as loss of body hair. Okay, so I'm going to, before I get back into my history, I'm going to set that all aside, but the point is that they have a lot of side effects. I had them, basically all of them. Now, there's some interesting history here. And because I'm in Canada, I'm going to present it. You may already know it. This is a picture of Charles Huggins. And Charles Huggins in the 1940s started looking at how he could help prostate cancer patients who, if they were diagnosed with it, they were going to die of it. Charles Huggins won the Nobel Prize in Medicine in 1966 for his original work on androgen deprivation therapy. Now, I happen to appreciate Charles Huggins, one, because I met him, but also I worked in Halifax, and he was born right near where I lived and worked. So he's sort of a Canadian hero, as a Nobel Prize winner here in Canada. He died in 1997 in Chicago because he was a professor at the University of Chicago. And he was awarded the Nobel Prize for his discovery concerning hormonal treatments for prostate cancer. Coincidentally, I met him in 1967, shortly after starting at graduate school at the University of Chicago. Back then, I had no interest in prostate cancer. I didn't know what it was, but I remember exactly where on the sidewalk someone said, "Oh, I got to introduce you to someone." And he stopped and introduced me to Charles Huggins. So I started on hormonal therapy knowing something about Charles Huggins. Since I didn't like the side effects of Leukerin, I started looking for an alternative. As a professor of anatomy and neurobiology, which I was for most of my career, I knew a bit of endocrinology, and I knew that the first drug Huggins used for ADT to replace surgical castration was an inexpensive oral high estrogen called diethylstilbestrol. So actually, Charles Huggins, when I sometimes tell this story to be a little glib, I say he got the Nobel Prize for castrating men surgically, which in fact he did. But he then moved over to drugs shortly thereafter. And actually, this is a curious aside. Recently, I heard someone comparing Canada to Australia and about how similar we were, except the Australians were more committed to having fun than we are in Canada. I think it has to do with the weather. However, I'm trying to think of an Australian hero as we look at it, and I think that would be Paul Hogan as Crocodile Dundee. Everybody knows him. Everybody in Canada knows that Charles Huggins got a Nobel Prize for emasculating men. So here I think we have the contrast. You guys are masculine, and we give Nobel Prizes to scientists to emasculate men. Anyway, staying with that, he obviously moved over to diethylstilbestrol, a synthetic estrogen. From Huggins' work, I knew that using a high-dose oral estrogen could suppress T. Now, we know that if we have a hormonal loop and high testosterone or high estrogen, has a feedback loop through the brain, to the pituitary gland, to the gonads to control our testosterone levels. However, it carries, that is diethylstilbestrol, although it can suppress testosterone, it carries a dangerous risk of blood clots. And this should not be a surprise. In fact, women have cycles of estrogen in their body, and it does increase clotting for good reason. We do not want the females of our species to bleed to death every time they menstruate. So that is a natural part of estrogen. However, the clotting factors are developed in the liver, and if we swallow estrogens, then we have a surge to our liver, and that's where the clotting factors develop. So going back about 25 years ago, some scientists in England decided that if they used it and applied the estrogen to the skin, they might be able to get good testosterone control, PSA control, without the risk of blood clots. Now, I learned that they were developing a clinical trial in the UK to compare high-dose transdermal estradiol to drugs like Leukerin for ADT. And I had communicated with the scientists, and I decided, even before they began the trial, that I wanted to explore this. The researchers thought that the estrogen might be safer if taken through the skin rather than orally, like DES. So we have a blood supply that goes right from our intestines to our liver for anything. So anything we digest can get to the liver and essentially be detoxified there. But if we take a drug through our skin, it goes into our circulatory system, and we don't get the surge to our liver. Now, I will come back to this, but the trial became known as the PATCH, the PATCH study, which started 15 years ago and had an accrued over 2,200 patients. So it's a huge trial run across the UK. And I started on transdermal estradiol for ADT before the PATCH study began, and have stayed on transdermal estradiol pretty continuously for over 20 years. Okay, so I'm going to take a sip of water here. I want to tell a eureka story. Eureka is a sort of thing where we imagine scientists discover something and they have a eureka moment, and I truly did have one. When I decided to go off of Leukerin and go on to transdermal estradiol, we did not know how fast to ramp up with the estrogen and how fast it would take for the leukerin to go down. So I was getting blood tests weekly. Now I had an oncologist, this was in Halifax, who said, all right, I'm willing to try it. If you're willing to, I'll try it, I'm willing to try it. But I was getting blood tests weekly. And after about 2.5 weeks or so, I felt so much better. I was totally convinced that this was failing for some reason, because I felt so much better and didn't have that brain fog, or however you want to describe it, that came with leukerin. I was pretty sure this wasn't working. And then I get a phone call in my office from my oncologist. It says, Richard, do you know what your testosterone levels is right now? And I said to her, Laurie Wood, Dr. Laurie Wood, I don't know, but I'm pretty sure that this experiment is failing because I feel so much better than I had on leukerin. She said, Richard, your testosterone is the lowest it's ever been. And that was my eureka moment, because at that point, I did not know whether this was for instance, a placebo effect. I thought it might be better, so I was thinking it was better. So I am a scientist, so what did I do? This is when this eureka moment came when I was coming off of leukerin and going on to TE2. Now, I needed to know whether it was a placebo effect. So I needed to study this in an animal that doesn't know about placebos. And therefore, we did some work with rats, and I'll tell you about in a minute. Now, in terms of the side effects, hot flushes, that is, as you call it, in North America, we say hot flashes, but you guys call it hot flushes. And they're due to loss of estradiol. That is, we men make estradiol from our testosterone. We go on ADT, we don't have any testosterone, we don't therefore have any estrogen. And just like women at menopause, we lost our estrogen abruptly, and we start having hot flashes. So patients on transdermal estradiol have far fewer hot flashes during both the day and the night than those on drugs like leukerin. And therefore, it can lead to better sleep and thus less daytime fatigue. And in fact, we studied this in rats. So we castrated male rats. This is a graduate student, Eric Laboa, who's now a professor in anatomy at the University of Sydney in Australia. We gave them estrogen, and we put electrodes in their brains. We looked at their sleep pattern. And if you are dreaming, we call that REM sleep. And it turns out that having good REM sleep helps to maintain cognitive function. And we showed that the rats slept better, had better REM sleep, and had greater activity during their activity time of the day. As I say here again, REM sleep is associated with dreaming and better cognitive function. So TE2 may be somewhat protective of cognitive function in PCA patients. I could go into that a little more in these questions, but this is yet to be rigorously investigated. So the castrated rats on a replacement estradiol also showed some sexual interest. And I have had this anecdotally reported to me by some other patients who have been experimenting with transdermal estradiol. Now, this doesn't bring their sexual interest or performance up to what it was when they were on testosterone. But I was going to get these videos from Eric. We have pictures of the rats on estrogen who have been castrated, male rats chasing the female rats around. Though it has not been shown for men in the patch study, that is this recovery of some sexual interest was not shown in the men in the patch study. But to note for my own self, those men were in their mid-70s. I went on these drugs when I was in my early to mid-50s. So I think this is real, and I think it needs further investigation. Now, preserving some sexual interest may have quality of life benefits that go beyond just the patient. So this is now sort of speculating on some of my other research, but I think this is something profound to consider. That is, ADT, when we get whacked by it, it affects us directly and can affect our partners as well, because they see us changing, they see us disengaging from them perhaps, being more tired, fatigued, being more moody, etc. Faced with how stated ADT affects men, many men withdraw their affection from and physical contact with their partners. And there's a reference to this at the bottom of the screen. They're embarrassed by the changes they're experiencing and are reluctant to discuss them with their partners. So this is from the literature. This is from my own work. And it goes back almost 20 years. However, this of us withdrawing from our partners can lead to depression and frustration in our partners. And that's serious. So it might be that even if we cannot recover full penile function and sexual ability, just recovering interest in our partners can help them mentally with their health. And this looks like a rather unique contribution of ADT that needs to be further investigated, but it's certainly different than what one expects with drugs like Leucron. Now, there are costs to the partners, as I've already said. I put these type of slides in all my talks. Studies going back to 1994, we're talking about 30 years ago, show that the psychological distress on partners of prostate cancer patients on standard ADT is even greater than that of the patients themselves. So when we withdraw, we change our personality, it does freak out our partners, and they take the burden. And there are a couple of papers here that support that going back to 2008. There's been many, many more since then. Withdrawal of intimacy in general, that is a hug, a kiss, or whatever, not necessarily loss of coital sex, seems to be the biggest problem. Loss of intimacy can harm both PCA patients and their partners. So standard ADT, this is inflammatory language. I've used it, though, in grad rounds in psychiatry and neurology. No one's challenged me on it. Standard ADT can cause a communicable, that means transmittable from one person to another, iatrogenic, that means caused by the doctor, psychiatric disorder. He's changed. We as patients have changed, and she's now depressed. Hypothetically, transdermal estradiol may thus not just lead to better quality of life for prostate cancer patients, but it may also mean better quality of life for patients' partners and in their partnership. This, though, has not yet been investigated. However, this issue about the impact of ADT on the partners is the reference for that is at the bottom. It is a partner's disease, and the side effects of these drugs impact our partners as well as us, for sure. Okay, so I'm going to go back to what I call my narrative therapy. And John, when he introduced me, mentioned that I write essays. And one of my own ways for coping is to write up essays about my experience. And I published 4 or 5 of them as my own therapy. And there is actually a common term called narrative therapy. It's been shown that cancer patients often benefit from having the experience of writing out their own experience. So anyway, I have my own narrative therapy. I published a series of patient papers, essays, not really research papers. And here was one of them, Prostate Cancer, Gonadal Hormones, and My Brain from 2014. It's available online. And I wrote in there, what I have learned from my experience is that the male brain, well, at least my male brain, when fueled with either testosterone or estrogen, functions quite similarly. The odd man out, literally and figuratively, is the neutered, i.e. the eunuch brain, which is deprived of both gonadal hormones and having no testosterone or estrogen. So I want to now shift into where the research is. So now you're the first people to hear at large about my own personal narrative, but I want to get back to what research backs this up beyond my own work with rats. The patch trial reported, I said 2 months ago, it's now 3 months ago, at the 2004 Conference of European Society of Medical Oncology. So that's a huge cancer research society. The equivalent in North America is ASCO, the American Society of Clinical Oncology. And major results in cancer are presented at these conferences. After 3 years of metastatic free, the data they had, after 3 years of metastatic free survival, I should say again, at 3 years of data, metastatic free survival was the same for patients on the TE2 arm, the transdermal arm, and Leucron arm for men who started without known mets. That is, they did 2 studies, one with men who started with mets and men who started without. And their overall survival was nearly identical after 14 years. Now, they didn't present their MET data, but I've talked to them, and their MET data shows similar survival. Hot flashes, here's the difference now between these 2 drugs. That is the Leucron and ADT. Leucron for ADT and estradiol for ADT. Hot flashes were far more common for men on Leucron, but uncommon for men on transdermal estradiol. Also, bone mineral density stayed high for those on estradiol, but went down for men on Leukeran. That's serious and important. If we're on drugs like Leukeran long term and aren't doing anything to protect our bones, we will get loss of bone mineral density. And if we fall, we are more likely to break a bone. And in fact, we are more likely to fall and break a bone on drugs like Leukeran. We don't know about the fall data, but we know that the bone mineral density is retained on transdermal estradiol. And the men on transdermal estradiol had a better metabolic profile. So we need more data on this, but they were less likely to show the cardiovascular, diabetic risks, and so forth, which is astonishing and profound. However, no drugs come without side effects. And transdermal estradiol increases the risk of breast development and nipple or breast sensitivity. And it will come as no surprise. The male to female transsexuals go on estradiol to develop breasts. And in that essay I referred to, I made a slightly glib comment again that typically us prostate cancer patients are not enthused about this. The transsexuals are typically not enthused about the fact that they don't develop breasts as large as they might. But overall, the transdermal estradiol provided better quality of life. Now, those data have already been published. I'll come back to that in a minute. Now, there is a potential of a breast cancer risk. In men, the risk of breast cancer in general is less than 1%. But in men who have a BRCA gene, there's a 10% increase in the risk of breast cancer. So I checked just yesterday with Ruth Langley. She's an oncologist, head of the patch study in the UK, and there has not been an increased risk of breast cancer in any of the patients. I have not seen any breast cancer in any of the patients on the transdermal arm of the patch study. So this is hypothetical, but at least in North America, we're increasingly encouraging patients if they can get the test, to be checked out for BRCA mutations and other mutations. Because if they have those, they not only have a family increased risk of breast cancer, but an increased risk of aggressive prostate cancer. So men with a family history of breast cancer should probably get genetic screening before going on transdermal estradiol for ADT. And here's a reference, and you'll see I buried in a bunch of authors. So these data were taken relatively early, but this was a detailed, intensive study on quality of life that looked at all sorts of variables, including breast development, hot flashes, and so forth. And it reported better overall quality of life, even for the men who developed, were bothered or to some extent by gynecomastia. They still reported better overall quality of life. And there's the information that was published after 6 months of data. But the final data, I believe, support this. I know they support it as well. So Dr. Langley, whose name I've already mentioned, is the lead science on the patch research study. And in her ESMO presentation, she made this final comment. Transdermal estradiol should be a standard of care ADT option for men without metastatic disease. Now, that paper, they're pushing hard to get that paper written up and submitted. They were trying to get it out this month, and they will publish the M1 data hopefully early in the year. So what is the status of transdermal estradiol becoming an acceptable standard of care option for men in need of ADT? And here we get to an issue and a problem that I'd love to have a discussion with you all afterwards. Because it turns out you can't just simply turn around and say, oh, great, doctor, I want transdermal estradiol for my ADT. It's a little more complicated. There are 3 problems. 1, there is no approved transdermal estradiol product on the market specifically for men. That is, there are no male patches or male gels that you can apply to your skin. There are no formal protocols for managing them. So I've heard of various patients who said, I've heard about the patch study. I've read some of the old literature showing that it is safe. I'd like to go on it. And their physicians can say, well, I don't even know what product to use. I don't know how often to get blood tests and so forth. So we have no treatment protocol and we have no product on the market. There's no documented evidence. And this is when the patch team contacted me about 3 months ago. Richard, we got a problem. And that is they went to see if they could get existing patches, these transdermal patches that women use at menopause, repurposed, as they call it, or relicensed to be used for men. And they were turned down. Now they're going back with more data. But they were actually told that we haven't had any demand from patients to want this. Well, of course, there's no product on the market. There's no protocol for treating them. There's going to be no demand. So one of the things that we're doing now, and I was working on this yesterday, is we're going to do a survey questionnaire through the Prostate Cancer Foundation Canada to find out if patients would be interested in this option, knowing about the various side effects and so forth, to establish use. And that, in theory, I mean, this is still in the development, but that could easily be run in Australia. And in fact, it's a good thing to run that survey in either Australia or Canada or both, because you have universal health care, which would cover for the cost of the drugs. Whereas if you go to the United States, where they don't have as much care, then it's going to be a big question of who's going to cover it, and do you have private insurance and so forth. So this is something to consider. So I want to take up these three issues a little more depth. There's a challenge for getting the product on the market. The patch research team in the US is pushing to get their official patch protocol published and then approved for repurposing the TE2 brand of patches that they used in their study. So they use the patches, not a gel product. They use the patches that are standard women use. They apply to the skin. For women who are dealing with menopause, usually it's one patch a week, and they change it once a week. Oh, let me get back here. So their goal is to get the license extended so that the product can be approved for men with prostate cancer. There is no formal protocol, I already mentioned that, for managing patients on TE2 products. So, for example, there are 11 different brands of patches on the market and a couple of different brands of gel. Even for the brand of TE2 patches used in the patch study, men needed to change the patches twice a week, and men varied from needing 2 to 4 patches at a time. They required some extra blood tests to get the serum estradiol high enough to suppress the teeth. So we're now in the realm of essentially personalized medicine. That is, a patient that's going to go in this, they're going to have a few extra blood tests to see that they've got the estradiol high enough to suppress their testosterone without, of course, going up into a range or being at risk of a blood clot, but the range is rather huge. So, but initially, every patient's different, so there's going to have to be some management issues here addressed. And will the urologists buy into this protocol? Well, we don't have it yet. We don't know. So one of the other things we're doing, and we've already done it, is we've submitted an abstract, myself and a couple of colleagues who are on transdermal estradiol for prostate cancer, to present as a poster at the American Urological Association meeting. And we have to wait to see if our protocol is going, our poster abstract is going to be submitted. But we're going to be pushing to try to educate the patients, the urologists, about what it takes to manage patients on transdermal estradiol. At this point, we really don't know. We do know that it's a challenge here, at least in North America, to get the urologist who might start patients on ADT to measure testosterone. So we don't know we can also get them to measure estrogen. I think they would want clear guidelines, and those aren't in place at this time. Okay. Informing the physicians about estradiol. So I already said at the top that we submitted an abstract. But there are certain safety issues around this. Safely managing prostate cancer patients, I'm reading from the middle there, on transdermal estradiol, whether following the precise patch protocol or using other transdermal products, requires attention to serum testosterone and E2 levels, so that they may vary greatly in individual patients, even when delivered by the same transdermal product. And so this warrants extra blood tests, and we need protocols for managing that. Care here falls in the realm of personalized medicine and takes more attention by both patients and clinicians than simply getting a depot injection of a drug, should say a drug, not Z drug, a drug like Leucron every 3 or 6 months. Then there are cost considerations. So ADT with the patches is an order of magnitude cheaper than using drugs like Leucron or Orgovix, Firmagon, etc. And so that's a major savings of cost, which would amount to hundreds of thousands, no, in the millions of dollars for countries like Canada or Australia. Yet, and here's something intriguing that we've dug up some literature, my colleagues and I. There's a 2 to 3 times difference in the cost of achieving the same level of serum E2 for various patch products currently on the market for women. And the patch research team, unfortunately, coincidentally, picked one of the most expensive patches. But we could actually bring the cost much further down using other product forms of transdermal estradiol, such as high concentrations of E2 gel, can bring the cost down by another order of magnitude or more. So by my own calculations, making some strategic decisions on the concentration of estradiol, where I apply it, when I apply it, and so forth, I'm now spending less than 40 Canadian cents a day for androgen deprivation therapy, which is like 2 orders of magnitude cheaper than drugs like Orgovyx. Currently, though, no TE2 products are on the market specifically for men, and no company can corner the market. So this is bizarre. One ever thinks that these companies are out for money, but because none of them can own estradiol as a natural hormone, no companies are currently seeking any patent protection for E2 itself. So this is where, and I will put a shout out, Sarah, I'd love to talk to you about this because this is an astonishing issue where an organization like Movember could help bring such a product to the market. And worldwide, we're talking about hundreds of millions of dollars saved. Looking for the future. Although unpublished, my review with a colleague, he's a PhD engineer in physical engineering, Dr. Robert Watson, we've shown that there are many variables that can influence absorption of TO2 into the circulatory system. Now, we've written up our draft manuscript, but we promised the patch team that we'll wait for them to get their 2 papers out before we submit our paper. And these include exactly where in the skin you apply it, the carrying agent used with a TE2, there are various ones that can be used, and the timing between application and blood draws. We also don't know what might be predictors of who would be most and least bothered by gynecomastia or breast sensitivity. And that's the survey we plan to do. We're now planning a survey of patients to find out their interest in TE2 as an option for ADT. And all of these things are worth further clinical investigation. I have a bunch of colleagues I've mentioned. Eric Roboa was my graduate student, and he ran my ADT educational project. He managed it when we started it up. Paul Schellhammer is a prostate cancer patient. He also wrote the introduction to our book, a preface to the book. He also is a prostate cancer researcher, and he's been using estradiol almost as long as I am. Robert Watson, I've already mentioned. Phil Zakaris is another Canadian researcher using estradiol. So there's a bunch of these people. At the bottom of the list is Paul Abel, and he was the original scientist who said that maybe TE2 is a safe, we can use it to control PSA by administering the estradiol, not orally, but through the skin. And he's the father of the patch study, but he died a few years ago of Parkinson's disease. And with that, I want to thank you, and I am open for discussion. And what I will do is stop sharing. And I see in the chat box there's already 5 questions. No one flagged me. John, is there anything there I should look at?
Yes. Okay. One question from Alan was, would a man's weight, i.e. being overweight, impact the uptake of T32 by their body?
Yes. I mentioned in the second to last slide that the way you apply it makes a difference. And it turns out the reason that it's so variable amongst men is the more fat you have under that skin, the more moderated is the absorption of the TE2. And all of the products for women have them putting it on their bellies or their thighs or their hips or whatever. But if there's other places you can put them on. One patient was trying, he's bald, he's putting it on his head. I mean, he's being adventurous here, but it does matter where you apply the gel. Good question. Next question. I have a hand up from Ross. Ross, are you unmuted?
No, I'm fine. Can you hear me?
Yep.
Excellent. Thank you very much, Richard. That was a great talk. Very interesting stuff. My question is, these days for castrate sensitive prostate cancer, advanced prostate cancer, quite often we're given things like abiraterone or enzalutamide, darolutamide, those sorts of drugs. Has there been any work looking at the impact of estradiol with those sorts of drugs?
No, unpublished. It will be the third paper that the Patch team will get out from the UK. It was an obvious question. And when you realize they ran their study 14 years, drugs like abiraterone and enzalutamide were not around. So they had to shift. So they started as soon as the patients were going on doublet therapy, intensified hormonal therapy, whatever word you want to use, they started collecting the data. And let's say this is confidential because I don't know, but the results are still the same. They didn't show that TE2 was worse if you use it with darolutamide or enzalutamide or whatever. But I don't know when they're going to publish those results. But that's two excellent questions right off the top. Thank you.
Right.
Any more? Are there more questions? I don't know.
Yes, there is. There's another one from
Graham is waving his hand there. Hold on a second. Graham, you have to be unmuted. Sorry, John.
Right, got there. I'm going for a more basic question now. As a sufferer, a castrate-resistant metastatic cancer person, I'm so sick of hormone treatment ADT. I'm a big sufferer. I was wondering I've asked the question, not getting a proper answer all the time. What's the difference between going ADT or even T2 than having an orchiectomy? Why not just go and have an orchiectomy done with? I hear this sounds quite as bad.
Okay, so that's, I'm surprised you're not getting an answer, but you remember, as I said, Charles Huggins got the Nobel Prize for using an orchiectomy. There's a presumption that it is because it's not reversible. The drugs like Leukeron, if you come off them, they're advertised as reversible, but they're not completely. Men, depending if they're on them long term, the best they can hope is about a 70% recovery of their testosterone when they go off it. And it turns out that I've seen actually papers by urologists assume that men would be upset to have an orchiectomy. But when men have elected to have the choice, it turns out one study that never gets cited out of the National Cancer Institute in the United States, going back about 18 years, showed that the men who actually elected choice to have an orchiectomy showed less distress. But one of the reasons was they didn't have to go back and get a PSA test every 3 months and get panicked. And there's not been a real study to show that there's any greater stress if it's elective. I mean, we're not talking about brutalizing children to make them eunuchs in some, cord of Byzantium. We're talking about a life extension procedure. So it's relatively uninvestigated. But one really interesting paper was published out of, I'm not sure, it wasn't North America and it wasn't Australia. But with doublet and triplet therapy, and with a high cost of additional drugs, enzalutamide, apalutamide, darolutamide, Nubeca, Xtandi, and so forth, these drugs add a huge cost, and they do add a benefit. Well, if you can't afford both Leukeron, when you're like, say, a country in Africa, you can't afford Leukeron. But if you had enough money, you could afford, say, enzalutamide. A case can be made for not trying to do Leukeron and enzalutamide, but having an orchiectomy and then adding enzalutamide. And they did a cost analysis, and they pointed out that cost-wise, this would be reasonable. And unfortunately, because they don't have PSA tests in most of the countries in Africa, easily available, men do show up there typically with metastatic advanced disease. And many of them, because of cost reasons, are still getting an orchiectomy, or they're getting diethylstilbestrol. And if we, again, I'm sorry for doing this, Eric, I don't see on the screen, but I can see an organization like Movember saying we could make ADT available, and here I'm not talking about countries, I'm talking about continents, to countries in Australia, okay, if we could get a protocol approved for topical transdermal estradiol that could be affordable. But I don't think people should rule out an orchiectomy. The side effects are ostensibly the same. There's questions about whether they are, the cardiovascular profile is different or not. There's one or two papers that sort of question it, but basically that's what got the Nobel Prize. And of course, I want to be a little clear that it wasn't just castrating men. All of what we know about hormonal sensitive cancers starts with Huggins. It wasn't just doing the surgical castration that got a Nobel Prize. It was realizing that breast cancer, ovarian cancer, are all hormonally sensitive. Okay.
Richard?
Yes, next question. Go ahead.
Richard, we've got a question from Yanni.
Okay, Yanni, I don't see you on my screen here, but go ahead, please.
I'm, for instance, currently on triptyroline and Xtandi. You were talking predominantly about just replacing.
Those are two standard drugs we use regularly here in Canada. Yeah, I use Leukeran because it's the earliest one and the commonest one, but triptyroline is another one in the same class.
Yeah. So you were discussing within your presentation only really replacing transdermal estradiol patches for the first generation of hormone treatments of ADT. If cancer is metastatic, and if it's necessary to be on whether it's Xtandi as well as apalutamide, darolutamide, whatever, is it still going to be as effective? I thought you may have partially answered the question previously, but I'm not quite sure.
We were asked that question early on, and I thought it was a good question. But the data are unpublished, and in that sense, this is not a definitive or authoritative answer. I have only informal communication from the patch team that they have collected those data and they have not seen a problem. But I don't know enough details. But there's no reason to assume that things are going to be worse. That is, you're doing two things. You're suppressing the production of testosterone with drugs like the LHRH drugs that we've talked about. And then you're adding other drugs to block the receptors for testosterone in the cell. So all we're doing is we're just suppressing the same hormonal loop to make testosterone with a transdermal estradiol or with Leukeran or Zoladex or any other LHRH drug. And therefore, we don't expect there to be a difference. However, if we preserve some of the energy, we don't have as much fatigue because the enzalutamide or Xtandi that you run adds to fatigue. So we might get the better outcomes. I don't know the data on that yet. That's still unpublished from the patch study. In some, I don't expect these to be worse. They may actually be better, even for patients on the combination. Did I answer your question?
However, a follow-up question, because you also said in your presentation, it's not known the optimal frequency or the optimal number of patches to be used. If we were to give the patches a crack, we'd have to go into an experimental stage as individuals to work out the best profile for our own use. And during that time, of course, the cancer may progress.
Well, that would be the number of patches that you need to find out. You could figure that out in a month. And you'd already have some protection from, you can start with 2 patches and then add another one if it wasn't effective. And then you can add another if it wasn't effective. So in 3 weeks, you could know. You wouldn't have to wait years. All right? You're just adjusting the number to get into a certain range of testosterone and estrogen. So it's a matter of getting extra blood tests. But we don't know whether patients are interested or willing to do that or not. And that's part of the questionnaire we've designed. If you had to have more blood tests, and when you started on these drugs? Would that be important to you? If the answer is no, I'd rather just slap on some. I'd rather get a depot injection for 3 or 6 months and not have to get extra blood tests. We need to know if that's what the patients think. So that's one of the questions we want to ask. I'm actually, you guys are asking all the right questions. I'm really impressed.
Richard?
Yeah, go ahead. Yeah, go ahead.
Richard, Brendan White's had his hand up for a while.
Okay, Brendan, yes.
Question.
Just a quick question. Given women are perceived to be less emotionally stable than men, does going on TE2 mean that men would become more emotionally unstable?
The women might find the language unstable. All right, so this is, let's see, what can I say about it? There's no question that us men on hormonal therapies, including just standard ADT, have greater emotional lability. All right, and then one of my personal essays, you guys are welcome to look it up. You could put a last name, Wassersug, that's how it's pronounced, and put NYT for New York Times. I published an essay because when I went on hormonal therapy, I was more emotional. If you are a good macho male, to cry is shameful. I do have this image, and maybe I'm a little overblown. That you guys in Australia are more macho than we are here in Canada, but you're more macho than I am. The patients who don't know this is why we offer an educational program, may feel so embarrassed. We report a case in our book about a guy who was watching a drunk drivers, a Mothers Against Drunk Drivers commercial, which was really emotional, and he found himself getting tearful. Then his teenage, I can't remember, his son or daughter, saw him, and he felt embarrassed, and he got angry, and he withdrew, and he just became a grumpy old man. The alternative is that for women to be more emotional, you call it unstable, I think was the word you used, they also see themselves as more empathetic. And for women to go to an emotional romantic movie or whatever and cry, they don't consider it a weakness. And in my essay that I alluded to, I make a parallel. And that is that if you go back to biblical literature, the model for eunuchs were they were seen as large, tall, had high-pitched voices, and there's an argument in the antiquities literature that our image of eunuchs and our image of angels is our image from eunuchs. And if you have the expression, and the angels cried, we don't think the angels are weak. We don't think the angels are feeling sorry for themselves. We envision them as crying because they saw the trials and tribulations of humans. And they were sensitive to that. And forgetting about the TE2, I'll come back to that because you asked me. But just for the standard ADT, about 15% of couples will tell you they're closer than they ever were since he was on ADT. And what's going on here? The doctors, I've talked to enough urologists. I throw this to them. They had a patient, they started on ADT. The patient's back with their partner in the office and sitting across from them. And the doctor says, well, how are you doing? Not clear he's talking to one or both of them. And they stop and look at each other and says, well, we never did this before, but we now share Kleenex at the movies. So this emotional ability can be interpreted as a greater sensitivity by men. I elected to interpret it that way. Okay. However, not all men do. And I would say more men are shocked, ashamed of it, and withdraw from their partners, which makes things worse, not better. Now, you asked about TE2. I can only speak for myself because but overall, the men on the patch study with the quality of life study reported they were doing better on the TE2 than on ADT in terms of mood and emotions. Okay. But I'm still emotional, right? Did I answer your question?
Yeah, I was interested in the comparison between standard ADT and the TE2.
Well, I don't think it's any worse. I think if anything, it's better. I feel more normal. That's all around overall.
Richard?
These are very personal questions. Yes, go ahead, Jim.
Bob Carnaby's got a question.
Okay, Bob. Yeah, I see you on my screen. Go ahead, please.
Yeah, Richard, I was on Lucrin following after prostatectomy and 6 weeks of radiation. Then I was prescribed 2 years of Lucrin, 3 monthly injections. The side effects you mentioned, I had all of those, plus a few more. I had this paresthesia, this tingling from the tips of the fingers up through the shoulders, across the chest and down the other fingers. I had itchy skin every day, which was almost uncontrollable. All sorts of things. So after 9 months of Lucrin, I gave it up. The quality of life was terrible. I was sort of feeling suicidal, although I never had the guts to carry it through. But, I had all the feelings like that. I'd rather not be here. But the good thing is that in that short period of time, it brought my PSA down to 0.008 below. It's held it there for, that was 9 years ago. It kept it down there for about 3 years. And then gradually over the last few years, it started to climb. But in the last 2 years, it's got to 0.1 and it's just sat there. Now, I don't know whether that's classed as metastasizing or it's about to. They can't find anything on a PET scan. And I'm dreading Lucrin again. I don't want to go back on a bloody Lucrin. I've been thinking of the alternatives, and when I saw this coming up, your story about the estrogen option, I've got very interested because sooner or later I'm going to go on it. But am I a candidate for it, given my history where it's probably spread, but they don't know where yet?
I would say no. I'm in the same situation. I've been in the same situation for over 20 years. I've gone off of ADT twice since I started on transdermal estradiol. My PSA started climbing immediately. I'm not going to. I want to stay on it. But there's, so you would be a candidate if you climb, but your PSA is so low. How old are you now?
78.
58?
78.
78. Okay, you and I are the same age. By the way, I went on it early enough that my skin is relatively smooth. I'm not losing my hair. I look young for it, having started so early on transdermal estradiol. You don't go bald. All right, so we're the same age. I know several guys in our age range whose PSA is so low and creeping up so slowly that there's no reason for them to go on any treatment. Here in Canada, the general convention is if your doubling time of your PSA is under 6 months, then we should consider reestablishing treatment. But you said it's staying around 0.1. So I think what you need to do most is stay healthy. Exercise, diet, and by the way, exercise for prostate cancer is a national program in your country. You've got the best prostate cancer researchers out in Perth studying prostate cancer and exercise. So you guys all know that if there's anything, probably, oh yeah, you guys, it's early in the morning. Guys, if this is over, go for a walk. It's summer there. Get outside, enjoy it. I mean, that's you're so lucky. It's raining here now.
Richard,
yeah.
We had Alan Barley. He's been waiting for a while.
Oh, I'm sorry. All right, so I went on a lecture there to the side. Alan, I'll let you log in a minute. Bob, you don't have anything to worry about. But I do want to say one more thing because it is a general point. What I don't think will work well collectively is every patient who wants to try TE2 goes begging individually to their oncologists or urologists, asking them to try it. I would like to see us get some stated protocols in place so you can brace it with your medical team. You can refer them to Ruth Langley and PATCH, and they'll be able to find the papers. But I would much rather see us not nagging our doctors and irritating them individually. All right. So anyway, but you are a reasonable candidate if your PSA starts climbing fast. Alan, I'm sorry for taking so long to get back to you. Your turn.
Okay, thanks, Richard. I hope I was a little late getting here, so I hope I'm not asking a question that you may have touched on, but probably not. The area of known as BAT, the bipolar androgen therapy, where the testosterone is deliberately engineered to cycle to really high levels and then back down to very low levels. That's had a fair amount of exposure lately. I'm just wondering what your feelings are about that in relation to the program you've been describing.
All right, I will give you an answer. And Jim, cut me off if this is getting too long and there's other people waiting. It looks like I see 13 questions in the chat box there. All right, so BAT has not extended life. It's improved quality of life. But BAT has become interesting because it turns out that when you put BAT and you come back with some of the other drugs, it appears to sensitize the cancer to those other drugs. So there's a lot still to be learned. In Canada, we do not approve BAT. It is an experimental protocol. However, our gonadal hormones do fluctuate at various rates. For men, our testosterone levels fluctuate through the day. For women, their estradiol levels fluctuate through the month. And it might just be that that these are things that are looking in the future, and this is all speculative, that the best way to administer transdermal estradiol is cyclic. So in that sense, because it works very well for women while it's cycling before menopause, this has led me to think that if we have bipolar androgen therapy, we could have bipolar estrogen therapy, but it may just be that transdermal estradiol may be more effective if you use a little more or a little less. And I actually have been exploring that myself. And that's why I think I'm guessing N of one subject that I've had such good luck. Now I'm going to throw out a glib line, and don't quote me on this, but if I had to bet, I bet that BET would be better than BAT, bipolar estrogen being BET. Okay, would be better than bipolar androgen therapy. But that's just a bet if I had. There's no research on it whatsoever.
Interesting thought. Thanks, Richard.
Jim here now.
Yep, your turn, Jim. Go ahead.
John, I think it's time that you thank Richard for his talk and then invite him to stay for our members telling their stories and asking their own questions, not necessarily about his talk. And Richard said he'd be keen to stay on. So if you could thank him and then hand over to Nev, and Nev can run an ordinary meeting from now on with an expert sitting in the background.
Sure, thanks, Jim. There was one other quick question from Yanni that maybe is worth answering, and that was, do you recommend a particular brand of 2E2 patch that are currently available for women? I suspect
I actually recommend the a transdermal gel, a product that's called estrogel. But if you really want to bring the cost down, because you can go to what we call compounding pharmacies, and you just raise the concentration of the estradiol in the gel 10 times. And that's one of the reasons I've got it cost so cheap. I'm using 3/4 of a milliliter of gel a day, which is minuscule now. And I had been on the patches. I've been on a couple of different brands early on. They're sort of funny looking. They can pick up stain or dyes from your clothes around the edge. So I actually prefer the gel product. And the patch team knows that. But their study was done with a particular brand, and they're working to get that protocol approved, which makes sense, right?
Okay, terrific. Richard, that's been a fantastic presentation. I'm sure everyone's got a lot out of it. And if you are able to stay on for the normal meeting, that's...
I'd be happy to do so.
Okay, terrific. All right, I'll hand back to Jim and Nev, and we'll take it from there. Thanks again, Richard. Really appreciate it.
Thanks, John. Thanks, Richard. Really appreciate that. I'd just like to ask Richard one quick question. In Australia, we have a PBS where anybody can, any drug that's been approved by the PBAC for the government, we get it for $30.50 or whatever it is, $31. To get TE2 approved for treating men with prostate cancer, which big pharma is going to be interested in having trials to get, I would imagine, a much, much cheaper drug like TE2 listed instead of their $3,300 Zytiga or whatever. So how do we go about getting a trial to get this drug approved?
All right. So these are the tricky parts that I don't think I or the patch study looked into ahead of time. We didn't see it coming. It turns out that when the first patches came on the market for women, they captured the market pretty quickly. Now they cannot, estradiol is incredibly cheap and none of them can own it. So they tried to, then other companies said, oh, they're making a patch. We'll design our patch to be different and we'll put it in the market. And by the time there were 11 different products on the market, none of them were making any profit. So all of the companies know that this is not going to be profitable. And therefore, big companies, you got Bayer is in there, Johnson. I mean, there's a whole bunch of companies that are in there that have a product. But with 11 different products, basically they're charging a fortune for the design of the patch, not for the estradiol. And this is why compounding it is a cheaper way to go. But how I can't do anything. I'm not an MD. I can't run a clinical trial. However, an organization like Movember, a prostate cancer foundation in Australia, has the power to say, look, we would like to work with you to run this trial, okay, and we'll endorse the product if it gets approved. But we need something like that. And it's not going to be as easy as saying, oh, I want to try this patch or have you not heard that men could use your patch too? They don't care. They're making so little money that they don't. This is the paradox. We think of the drug companies, all interested in money. Here they can't make any money, so they're not interested. And we could be improving the life quality of hundreds of thousands of men every year if they had this option.
Like we got a job for November or PCFA or
yeah. I'm happy.
Yeah.
I'm happy to talk to on both organizations at any level because I think it's such a real need.
Yeah.
But I'm biased by my N of 1. No, I'm not biased by my N of 1. I'm biased by my N of 1 by watching the rats myself and seeing the results from the patch trial. This is not something that is just hearsay or an alternative to a regular therapy. This is credible, going back to a Nobel Prize. Okay.
Yeah. Thank you very much, Richard. Now we've got a number of people on here today. Is anyone who'd like to comment about themselves? John.
No, I was just going to let Richard know that Sarah had to go, but she'll email him soon and thanks him for the presentation. So that was just letting Richard know that. That's it for me.
Yeah. Thanks, John. John Dunkley.
Yes, my name's John. I've just come down to undetectable, less than 0.01 PSA, diagnosed a year ago with high volume metastatic prostate cancer. I'm tired of the Nubeqa, but grateful that it's brought me to that point. With my oncologist, I am considering coming off finishing ADT in February. I'm having a holiday, if you like. My problem is I won't want to come back on it. But I suspect after some time my PSA will go up. There is talk now that after 2 years on ADT, that they're thinking of stopping it and let your PSA rise a bit more before they look at going back on. But there's no studies to show what's the optimum time. So anyone's thoughts? I'm a bit apprehensive about finishing up in February with Eligard and Nubeqa and just having a monthly PSA.
Any comments to? Yes, Alan.
So I did exactly that after a long period on ADT and abiraterone, with similar PSA results to yours. My oncologist and I agreed to give it a try, mainly to eliminate some of the potential side effects. And pretty quickly, the PSA went straight back up again. The tiger leapt out of the cage, you might say, and I finished up with stereotactic radiation to nail a couple of recurrent lymph nodes, 2 separate occasions. So I went back on the meds, second time around with the stereotactic in conjunction with meds, indicated some synergy or cooperation between the 2 techniques. And so far, my results since then have been like yours, but with the meds continuing.
Mm.
Thanks, Alan. Yes. Richard, did you want to say something?
I don't know if it's appropriate for me to be, throwing in comments here. But to be clear, intermittent hormonal therapy was proven not to be inferior to continuous therapy. That doesn't mean it's necessarily better. And in fact, ADT typically works best the first time you try it. Now, I'm biased because I really feel my life is good on my current ADT program, which is transdermal estradiol. But if you're miserable on your standard ADT, you might ask, could I shift over? Because that's what I did 23 years ago, to switch over to transdermal estradiol. But again, that's going to be an issue you have to discuss with your doctors. But I'm reluctant to go on intermittent. I would rather do everything I can to live well, and that's how we developed an ADT educational program to help men live well on ADT. And when you, Bob, when you, for instance, mentioned all the side effects you had, some of them can be avoided. But what's tragic is when I get people who want to take our class to learn how to manage the side effects after they have diabetes, and they have tingling in their hands and could be going blind. So one can manage the side effects. And I think in Australia, you're trying to develop programs there to help patients manage the side effects. But certainly our ADT program could be brought to Australia. To be clear, you can get free of some of the side effects of ADT if you go intermittent, but that doesn't necessarily give you improved life expectancy. It isn't necessarily worse, but it doesn't necessarily say, oh, I only have so many months of my life on ADT. If I split it up, I'm going to live longer, or so many years. If I split it up, I'm going to live longer. There's no evidence to support that. And Ross has his hand up, so I should shut up. Thank you.
Thanks, Richard. John, there's a guy in Toowoomba. He's got one spot on one of his ribs, and he's going to have high beam radiation or such to that rib. He's going to have 2 or 3 sessions, one session getting mapped out, and then 2 or 3 sessions of high beam radiation to it, and hopefully that'll drop his PSA. So we'll see what happens there in the near future.
That's me, Nev.
Hey, pardon? Oh, you're here, David.
Yes.
Oh, I can't even see you.
Uh-huh.
Oh, yeah, I see you now. You're right beside John.
Uh-huh. So
sorry about that.
No, that's okay.
Blew your cover.
Yes, having those zaps on the 16th and 18th. I've had the planning session just this week.
Oh, well, all the best with that, David.
David,
thank you.
David, is that does that mean then you hope to stay off ADT, or will you just continue with that?
That's all down the track to be decided.
Okay.
Yeah.
Okay. Good luck with that. Thanks.
Thank you.
Any other comments?
That's after 11 years of being on ADT, because when I was diagnosed, there wasn't any PSMA PET scan available. So, and I went on hormone therapy and then it started to rise, and then on enzalutamide started rising again and got to 0.2. I had a PSMA PET scan just about 3 weeks ago, and that's the first time in 11 years I've ever known where it spread to one rib. No indication that that's where it's been all that time. But it could be microscopic, lots of other places as well. But I was pretty excited. I don't think I've ever been so excited about having radiation therapy ever. I had, part of the initial treatment was the prostate bed, 33 sessions. So this is just 2. So see how it goes. I'll keep you informed.
Good luck, David.
Thank you.
Jim here for everyone. If you turn your microphone on to speak, then turn it off when you're finished, please, because otherwise when you clear your throat or whatever, your picture jumps up. Nev, we have Ross Chapman has been waiting a while.
Righto, Ross. Sorry about that.
No worries. Thanks, Jim. Thanks, Nev. I just wanted to report on something that's happened to me recently. My story is very similar to many here. Prostatectomy back in 2021, Gleason 9, went on radiation, EBRT, plus ADT for about 10 months, and then came off it. And after 3 months, PSA started rising again. So I'm now back on ADT and darolutamide. Have been on it for about 12 months now. I've been having problems with neuropathy and weakness in my legs and feet. So I've been seeing a neurologist and now a neurosurgeon who said, oh, yes, you've got a nerve jammed in the bottom of your spine. And he blamed the radiation for it, which surprised me immensely. He said it's arthritis plus radiation that you've had has caused that. And we need to do some surgery to fix that up, which I'm not very thrilled about. And I'm not sure I'm going to do it or not. But I had no idea that radiation can affect the spine in such a way. Even this was only 35 days of external beam radiation in the pelvic area to try and catch any spread. So my PSA is still very, very low, and it's still, no one knows where it is. The PSMA PET scans don't show anything, but I'm still on Leukerin plus darolutamide to try and stop it growing elsewhere in the body. But my comment here for the group is this issue of radiation, the radiologists tell us it's fantastic and no side effects and it's all this sort of stuff. It does have an impact, and sometimes that impact appears to be longer lasting than they will tell us.
We have Richard Nev to make a comment on that, and that's Alan.
I have my own personal version here in Canada. When I went for salvage radiotherapy, I asked about long-term effects and risk of secondary cancers and so forth. There is a slight tiny risk of secondary cancers from the bowel, from the radiation. But the line I got was, if unlikely you have any problems. If you're going to have problems, they're probably going to be 20 years from now. And unfortunately, it's 20 years. And I've had some neuropathy, nerve conduction studies done. I'm a little unstable on my feet. I haven't fallen, but the neurologist thinks it was due to the radiation over 20 years ago. So there you go.
That's interesting. It's exactly what I'm going through. Neuropathy, balance problems, and now weakness caused by this jammed nerve in the bottom of the spine. And again, the blame given to a combination of arthritis and radiation therapy, which is only a small set, like 35 days. But he said, no, that's what's caused a lot of the problems in your lower spine. So
how long ago did you have the radiation?
Less than 2 years ago.
That's a little different than my situation, but yeah. Thank you.
Thank you.
Thank you. Who'd like to go next and tell? Yes, Alan?
Just in response to Ross's point, I've also had peripheral neuropathy in my lower legs, particularly feet, the symptoms of which a bit like the feeling of the feet wrapped in bubble wrap, a bit uncomfortable on any surfaces other than soft carpet. And I also have a lot of trouble with my feet being cold, and I wear socks nearly all the time. So I've not had chemotherapy, which is one of the usual suspects for peripheral neuropathy. It's just been ADT with abiraterone and a bit of steroid. I have had conduction tests, a couple of real. The rate at which impulses are carried down into the lower leg is relatively slow compared to what it should be. I have at that stage when I first encountered this, which is probably halfway through my nearly 20 years of experience with drugs. But that certainly predated any radiotherapy I've ever had, which has been much more recent, and which hasn't been directed at bone. It's been directed at lymph nodes or more recently with a different cancer with chest nodes. But so I wouldn't jump to conclusions too quickly that radiation is the cause of it. Certainly wasn't in my case, but the symptoms sound very similar. I have a feeling that I've occasionally heard these stories from other people that there's an under-researched area for people on long-term ADT, a proportion of whom I suspect are susceptible to this particular problem. Again, not chemotherapy-induced, but perhaps ADT or ADT plus second-gen treatments. So I've got no evidence for that, but other than a couple of other anecdotes.
And Nav, Gabriel has been waiting for a while.
Righto. Yep. I can't see him. Oh, yeah, I can see up in the top left-hand corner. Hey, Gabriel.
Hi, how
Welcome.
Everyone else, thank you. I just wanted to introduce myself to the group. This is my first meeting, and I found it very helpful and informative. I was diagnosed with advanced prostate cancer 5 months ago. And to cut a very long story short, my Gleason score was 5 + 4. I'm only 63. I thought I was healthy, but due to some mismanagement from my former GP, my prostate cancer has metastasized significantly, leading me to being on ADT. So I've only just started on ADT. So I'm currently having quarterly injections of Leukerin, and I'm on daily doses of darolutamide. And I've been led to believe that that's my lot for the remainder of my life. So I don't have any particular questions. I just wanted to introduce myself and say this is all very new to me. I'm just absorbing as much information as I possibly can, and want to thank you for welcoming me into the group.
Just a question, Gabriel. Some of us believe that 3 monthly hormone injections actually means 84 days. I was just wondering how often do you have yours? And there's a bit of conjecture there about whether it should be 84 days or 90. But some of us seriously believe 84 days, and I'm not sure what Richard thinks about that.
Yeah, look, I don't know what to say to that. I've been informed it's 3 monthly, and I've only had 2 Leukerin injections so far. So I've been led to believe by my oncologist it's every 3 months. So I don't know what else to share on that.
Yes, Richard?
The technical answer is that if you're tracking your testosterone with your PSA test, you can know. I mean, in theory, there may be patients who, and this is the area of personalized medicine, there may be patients whose testosterone starts to climb after 80 days, and others who the testosterone doesn't start to climb after 110 days. So this is why I like to get a testosterone measurement whenever I get a PSA test, and make sure that it's as low and it stays low. Right.
Thanks for that, Richard. Someone else like to ask a question or a comment, or
just a very quick one.
Yanni?
Sorry,
Alan.
So I'd just like to make the observation that that my urologist has basically said that the ADT doesn't fall off a cliff at the end of the period that it's you're taking it, and that it slowly drifts away. So it doesn't really matter whether it's a couple of days this side or that side or whatever. But the second point I'd like to make to Gabriel is make sure that you, since you've just started hormone treatment, make sure you go and get a bone density scan, because as Richard mentioned, that's one of the side effects of going on to hormone treatment, and you need to have a base level against which to compare over time what remedial action you need to take to protect your bone density. I for one, so that's a DEXA, DEXA scan. I, for one, have had my bone density go down from healthy into osteopenia, where it's now floating around and has for the last few years as a precursor to osteoporosis. Very important, Gabriel.
Thanks, Yanni.
And make sure you keep all of your records of all of your blood tests and all of your scans and all that stuff, so that if you do need to go see some other onc, then you can just haul it off and present it to him, and he'll have all he needs in front of him.
Thanks, Yanni. I'll go to Ray Lane, then I'll go to Bob Owens.
Ray from the Ocean Reef Prostate Cancer Support Group in WA. My question for Richard is, are you familiar with the PROST exercise program, Exercise for Men with Prostate Cancer, that was developed by physiotherapist Joe Milios in Perth, and the work that PROST is doing specifically for rehab and prehab for ADT
Yes,
patients?
I am. I have been to Perth. I have met with her. Her enthusiasm is really appreciated. Everywhere we're pushing anything we can to get men on being treated for prostate cancer to exercise. She's got one of the programs. There's separate programs of various natures around the world, but she is a well-known advocate for exercise. And you guys are distributed across your continent. I understand on the screen now, but for local support groups here in Canada, I encourage them all to become not just meetings where some nerd like me talks, but also have some exercise program, even if it means walking to a pub or a coffee shop, but engage activity in with the dissemination of information and sharing of information. So yes, I am aware of that.
Thank you.
Thanks, Ray. Bob Owen?
And Ross has his hand up.
Sorry, I just had the one move. I'd just like to share my story and just for a comment, if I may. Back in May, my PSA doubled within a period of 3 months. They sent me off for a PET and CT scan, which resulted in the report for that coming out remarkable treatment result. In other words, they couldn't see anything. It had metastasized to some places. It wasn't visible. It had gone cold, it had gone to sleep, it disappeared. So they thought, well, it must be coming from the primary source, from the prostate, which I still have. So they said, okay, we'll do some radiation to the prostate. And I had 5 intense doses over 5 weeks. And while that was happening, this is a question for the professor, if I may ask later. While it was happening, I complained about the side effects I was getting from Digaralex or Firmagon. It was making me very sick, and I couldn't. And I asked, could I change? And he said, yes, okay, we'll change you to Eligard. Now, at the end of the radiation, I had another PET scan. Still couldn't see anything, nothing visible, and yet the PSA had gone up quite, well, not substantially, but quite a lot. And that took everybody by surprise. But the question to Professor is, would changing from Firmagon after 18 months to Eligard during this radiation, I know Eligard causes a surge in PSA when you first go onto it, but would that change have caused the PSA to have gone up the way it did? I know that's a difficult question and probably not answerable. The oncologist said, well, okay, it's gone now to 2.4, but the doubling time was getting longer. To get to 2.4, it was doubling over, that was 6 months. He said, well, let's wait till the end of January and we'll have another one because it's just irregular. And it took them by, as I say, it took them by surprise. It went from 1.1, 1.4, 1.8, and then 2.4. So that's what's happened. But the question is, do you think the change to Eligard could have caused this aberration in the level?
The standard here if a patient comes in with a high-grade disease and you want to get the testosterone down fast, is to start them on Firmagon. Or if they can afford it, in North America, we don't even have it here in Canada yet, Orgovyx, which is an oral version of that same type of drug. And so switching to Eligard from Firmagon is common. The increased rise in your PSA in part may be due to the fact that you've had the radiation. And think about it, the radiation is killing the prostate cells. They're dying. They're full of PSA. They're going to leak that PSA of the dying cells into the blood. So you can get a little bit of a peak rise in your PSA after radiation. But it's due to dying cells, not to growing cells. And that's an important point to realize. So I think you're going to have to wait till January and get another test to see whether things are stabilizing. But typically, switching from if you're already on Firmagon, you can switch to Eligard without necessarily provoking extra growth or a meaningful surge. If one is worried about that and they did a testosterone test along the way, then you'd actually see it in the testosterone. You'd see a rise in testosterone. And typically we don't see it in that situation.
No, I asked about the testosterone level, and he said, no, it's still suppressed. It's still within.
There you go. So what you probably did is you got a rise in the PSA due to the PSA leaking from the cells that were killed by the radiation. And don't worry about it at this point. I support your doctor's advice because they're real doctors. I'm just a PhD doctor.
Thanks, Richard. Thanks, Bob. Alan, I'll get to you after I go to Ross. Ross has had his hand up for a fair while.
Okay, thanks very much. I just wanted to make a comment about just Richard's statement about going and get a testosterone check. The issue in Australia is that the government is trying to crack down on pathology costs. So even to get our 3 monthly PSA, I have to sign a declaration to say I've got prostate cancer. That's why I'm getting it every 3 months. When I asked my specialist, can you put testosterone on there as well? He said, oh, no, you don't need it. It's suppressed. So we don't get testosterone anymore. It's much more difficult to get these pathology results in Australia because of the cost of Medicare. If you pay for it yourself, you can, but it's really expensive, like hundreds of dollars every time you get a testosterone test. So that's a bit of a problem for us in Australia, given the government's stance on the cost of Medicare and pathology results.
Thanks, Ross.
Dev?
Yeah.
Because time is moving on, is there anyone?
Well, Alan wants to. I think Richard was going to say something, but he hadn't unmuted himself, and then I was going to go to Alan.
All right, I just unmuted myself. I unmuted myself. I'm sorry to hear this, but this is going to be one of the problems with getting a trial up and getting a product on the market. And actually, Paul Schellhammer, I mentioned, is a past president of the American Neurological Association and a colleague and a collaborator. He and a urologist threw his hands up and said, we're going to have a problem here. I mean, if we can't get the urologist to measure testosterone, it's going to be a challenge to get him to measure estradiol. But if there's a product for men, it's going to be like 3 measures early on when they start, and then you can stop doing it, that may make a difference. And this is why we need an established protocol for the TE2. Yeah, and I have good support with my own doctor. So if I want to get a testosterone test here, I get it because nobody's stopping me. But I'm sorry to hear that. That's a challenge. Yes.
Yeah, Alan.
No, sorry. Can I just make a comment on? Maybe it varies by state, because every time I have a PSA test, my testosterone levels are measured for free, just for what it's worth. In Victoria.
I just wanted to talk to the chair, Nev.
Yeah.
I was wondering whether there might be anyone who hasn't told us their story before we have further ongoing debate about these other questions.
I can't see anybody new with their hand up.
Well, ask them to talk.
They're shy.
That's fine. Okay, thanks, Nev.
Yeah, Alan?
Just going back to Robert Owen's situation, another possible explanation beyond dead prostate cancer cells, secreting PSA, could be that you mentioned you're getting pretty inconclusive results from PSMA PET, but a significant proportion of guys with metastases do not have PSMA on their surface of their cells. And to identify those, you may want to have a chat to your docs about an FDG PET scan, which is going to pick up fairly likely those tumours which are not being made visible by PSMA PET. So just another line to consider.
Is there anyone that'd like to speak that hasn't already spoken? Well, make you the last one then, Yanni.
Another question for Richard. As I mentioned before, I'm on enzalutamide. Alan, for instance, is on abiraterone, and sooner or later the enzalutamide will stop working, and Alan's abiraterone will stop working. Now, as I understand it, research has shown that if Alan were to go on to enzalutamide and I was to go on abiraterone, it'd have marginal utility. What would you expect the profile of a patch to be in that sort of circumstance? Would it be more effective than changing from a normal?
I can comment on that, but it's going to be somewhat what I've said before. As I understand, the benefit for prostate cancer control, it doesn't change when you add the second agent, they're called ARTAs, ARPs, and so forth, the abiraterone, and then the enzalutamide, darolutamide, apalutamide. So I don't know what we could expect, whether it's going to change the effectiveness of the second, that is, using transdermal estradiol for your primary DT. Will it change the effectiveness of switching your RPs if you're using them as a second agent? But we're nowhere near doing that study. We first need to show that we get comparable prostate cancer control. That said, there are cases for and against changing the RPs. And one of them is that they have not been shown to be that effective. That is, if one, as you exactly said, if one fails, you don't get necessarily a great advantage if you switch to another one. But their side effect profiles aren't exactly the same. So, for instance, very slight differences, but a risk of a fall and risk of fatigue appears to be higher with enzalutamide. Risk of cardiovascular side effects a little bit higher with abiraterone. So at this point, I mean, if there's a case for switching, it's probably because of your whole overall health status. If you've had osteoporosis and a broken bone, that's might suggest one is better than the other. If you already have had high blood pressure and an angina or a mild stroke, that might suggest the other is better. I think it is the side effect profile and the risk of comorbidities that would be a case for changing. But for actual cancer control, we don't see it with standard ADT plus the ARPs. And I'm guessing we won't see a change either if it goes to transdermal estradiol and the ARPs. But that's just a guess because nobody's done the studies. Did I answer your question?
Thank you.
Thank you very much, Richard. Thank you very much, John, for inviting Richard to our meeting today. Richard's presentation has been extremely well presented, and I'm sure everyone will agree with me that he's had a lot of important information that we can share, and we've got a lot of work to do on getting estradiol or TE2 a little bit more easily available to men with prostate cancer, advanced prostate cancer. And I'd just like to thank you once again for everything you've done for us today. It's really appreciated.
Well,
and we wish you all the best.
Thank you for having me. And guys, get outside, enjoy the summer. I'm jealous.
Yeah, all the best for Christmas, everyone. See you in the new year. Thank you. Bye.